All right, I'm going to introduce our next speaker, and he sent me his bio really late, so it's on my work computer and I didn't print it. So I am just going to tell you that this man is absolutely fantastic. He is a homegrown Edmonton boy, and we're very grateful to have him here. He makes me excited to stay here and get treated here because he's just absolutely brilliant, and we're lucky to have him. So without further ado, Dr. Michael Chu.
I was going to say, when you get set up like that, I mean, it's only downhill from there.
Making sure you stay.
That is the plan, to be honest. But obviously, I'm well too embedded to really even think about leaving, quite frankly. So. Hey, I was gonna say that it's kind of like the Oilers were a two-man team, so you keep Sandu and I together, then it's like Draisaitl and McDavid. But I figure they're making quite a few more zeros than either he and I are. So I laughed because the last year, every December we have an annual hematology conference in San Diego, so ASH, and it was the last night of the conference. And both Dr. Sandu and I were, really tired after a very busy conference. And what did we pick? Shake Shack as our last meal before leaving. So anyway, so I got asked to talk about cell therapy and immunotherapy, but quite honestly, and as we were chatting with some of the folks in the room here, there's such crazy advancements in myeloma that I thought I would take a step back and do a bit of a discussion as to some of the things that are happening that are not immune therapy. In other words, some of the earlier therapies. Now, to be fair, some of this unfortunately won't apply to yourselves just because this is going to be in newly diagnosed patients. Having said that, it kind of gives you a sense as to where the overall changes and advancements are happening. And part of it is just because this is all happening relatively recently and quickly. So in my agenda here, I'm going to review some of the treatment algorithms as they exist today, talk about some of the updated combination therapy, then obviously getting into some of the other more immunotherapy updates. Yes, 100%. So to review, remember that myeloma is a bit of a weird disease. Whenever people think about cancer therapy, thank you. They think about cancer as a clone. In other words, everything is a copy of each other. Think of Dolly the sheep. That's actually not the case in regards to myeloma. And quite frankly, we're finding that a lot of the other malignancies are very similar in that instead of clones, it's actually a whole family of cancer cells that are occupying the little spots. So in a myeloma patient's bone marrow, as opposed to having all copies of the letter A, what happens is actually you have A's, B's, C's, D's, E's, and F's. And in fact, actually, I think of it more as having a whole family tree. You've got the moms, the dads, the babies, you have aunties, uncles, grandparents. And as you can imagine, they are all a little bit different from each other. And so what happens when people, or you read about things like clonal heterogeneity, that's what is reflecting. The other part is clonal evolution. Clonal evolution, I'm not really quite confident of that. That refers to a terminology of thinking that by applying some type of chemotherapy, we're causing the cancer cells to change. Maybe, maybe not. The jury's out on that. What is probably happening is that if you give a particular chemotherapy, the aunties and uncles all die from that chemotherapy, but the grandchildren are resistant. And after you kill off the aunties and uncles with chemotherapy number one, those resistant grandchildren start to grow and multiply. And as a result, that's where it becomes a bit more difficult the second time around, and that's what usually necessitates and requires a different type of therapy thereafter. And so that is the reason why there's so many classes of therapies to go after these different populations. You want to add a chemotherapy that can target the aunties, and then another one that targets the uncles, and then the last one, of course, is the grandchildren. And that's how you actually get rid of enough of the cancer cells so that hopefully someone actually gets a remission, and obviously the hope in the future is to actually get a cure. But this is what this figure is basically pointing out, and that essentially that what happens over time is that the population of the cancer cells change, and that's part of the reason why over the course of a patient's experience with myeloma, it changes between different relapses because it is different between each one. So traditionally, we've been talking about, of course, different classes of therapies, proteasome inhibitors, things like bortezomib and carfilzomib, immunomodulators, lenalidomide, pomalidomide, as well as anti-CD38 antibodies and stem cell transplants. Now, the algorithm is complicated, to say the least. And I was just reflecting with someone else that whenever trainees come to myeloma, you can see being the deer in headlights just because they see the algorithm and go, I have to know this by the time I'm a doctor. I'm like, most of it. So to be fair, that's part of the reason why that it's still only Dr. Sandhu and I doing this at this point, just because I think that it is a bit daunting. Now, to be fair, lymphoma and leukemia, CLL as NAN treats, is starting to get that way as well. And that's just because, again, we're understanding more of the disease and the underlying biology, which then dictates the therapy thereafter. So really, you're not going to be able to see this from the back of the room, but the basic idea is we divide patients into who we consider to be transplant eligible and those who we consider not to be transplant eligible. That also, too, has changed over time. So in other words, the people that we apply to transplant to has changed. The idea, of course, is that as we have less toxic therapies that are more effective, that actually has moved the needle. Where do we really have to transplant everybody all the time? And the answer is no, we don't. And so in fact, actually, who we consider to be transplant eligible has continued to whittle down, simply just because we don't always have to in order to get the same types of remissions and the same type of expectations. So the general rule of thumb now is for someone to be under the age of 65, because the more recent literature finds that people over the age of 65 don't seem to get as big of bang for buck because of these new therapies. The other part, of course, too, is that something called a tandem transplant, doing a back-to-back transplant, has really fallen out of favor. And part of it is just because it's really toxic. So for those who've gone through a transplant, you know how tough it can be. And quite frankly, asking someone to do it twice in the span of 3 months, it's kind of a tough ask. Now, that's not the same everywhere. Our colleagues in Montreal still very much believe in it. And so, in fact, for patients that are under the age of 50, they will still chase after a tandem transplant in those folks. We've tended not to do that as much anymore. Our own internal data suggests that it's probably not that useful. And if anything, it actually really beats up the blood cells and a lot of transfusions, infections that happen thereafter. Now, what happens after the first line of therapy? Really, the first line of therapy hasn't changed too dramatically in the last 5 years. Well, it kind of depends on what you got beforehand. So this is the slide that really drives the trainees crazy because they're trying to figure this out. And in a pressure situation, when they're doing their licensing exams, they get asked to go down each route by memory without having to be able to draw it out or stare at it. So you can imagine what kind of the oral exams they have to go through. So I do feel for them. When I did my oral exams, it was nowhere near this complicated. But to be fair, Dr. Sandhu and I have contributed to making these algorithms, so oops. So really one of the more main therapies that have essentially really changed the way we treat is the CD38 antibodies. So CD38 basically is a protein marker. It's like a barcode on the outside of the myeloma cancer cells. And it's something that's very unique that stays on the cancer cell that in fact, actually a lot of the other cells in your body doesn't actually continue to express. So it's very specific to myeloma cells, which makes it a very easy target, because if you go after this, you don't actually have a lot of side effects that happen afterward. So the classic example of this is daratumumab, and there is another one I'll talk about in a few minutes here called isatuximab. But the idea is that it is a little marker on the outside of the cell that this antibody can go after and basically raise a flag and trigger the rest of your immune system to go and kill that cancer cell. Trying to advance the slide. There we go. So more details about this. I'm just going to leave this up there for your sake. Realistically, daratumumab is an antibody-based therapy, which is not like chemotherapy. That's part of the reason why that you actually have to take the prevention medications, things to prevent you from having an allergic reaction. In fact, actually, daratumumab was originally designed off of a mouse's immune system, and so while you won't turn into Mickey Mouse, your body will recognize that it's not clearly human completely, and so that's the reason why you had to take things like the montelukast in the very beginning, and it's still taking things like the antihistamines afterwards long term. Now, despite the fact that obviously it goes after myeloma cells, it does go after some parts of the immune system, and that's why there's some concern for these viral infections like CMV afterwards that can pop up. These are old viruses that you have been exposed to as children, and then unfortunately kind of sit in the dormant in the background until your immune system goes down, and then it can wake back up. Isatuximab is in fact actually was designed before daratumumab, different companies. So this is where you get to peek under the hood. From a pharmaceutical perspective, the two different companies were developing both of these drugs at the same time. Sanofi had isatuximab, and they actually started developing it before Janssen developed daratumumab. But Janssen realized actually they were sitting on a diamond in the rough and poured tons of investment into it, whereas Sanofi was much more conservative about it. So unfortunately, daratumumab ate most of isatuximab's lunch. Having said that, Isatuximab is still a really good drug, and actually now we actually use this in unique scenarios depending on what types of drugs people have been exposed to. So because they're two different drugs, interestingly enough, despite going after the same target, they combine differently with different drugs. In other words, sometimes mix A will work for daratumumab, but not the same mix for isatuximab. So depending on the scenario, patients nowadays may get isatuximab as opposed to daratumumab, where daratumumab was really ubiquitous. Everybody got daratumumab, I would say, just a few years ago. But in the last 2 years, we've been using a lot more isatuximab in specific situations. So the biggest drawback to isatuximab is that it has stayed intravenous, whereas those that are on daratumumab know that a subcutaneous shot being 5 minutes is far simpler than having to sit for an IV, and obviously a little bit less painful. I mean, the pinch in the tummy versus the trying to fish for a vein kind of speaks for itself. But this is where, again, the modern combinations come into play. And so last year I presented this slide here. This is called the Griffin trial. So Griffin is basically where they decided to take a whole combinations of different therapies. So as it goes right now for newly diagnosed myeloma patients, traditionally we give them a 3-drug combination with bortezomib, lenalidomide, and dexamethasone. Now, this study added daratumumab and tried to look at it in a transplant-eligible population. How did they do? And so, in fact, actually, what it shows here, and you're not going to be able to see it too well, the bottom line here is that the quadruplet therapy with daratumumab added to the backbone has done bonkers. In other words, it has substantially improved the outcomes of these patients up front. Now, obviously, we haven't followed these guys out long enough to see what happens long term, but as far as we can tell, the remission as it stands right now is trending towards about 8 to 10 years after this first treatment. And that's quite remarkable. Remember that for newly diagnosed patients, we have traditionally been quoting them a survival of somewhere around 10 years. And so if you're getting 8 to 10 years of just your first remission without seeing any other therapies, that really moves the goalpost. So, this is quite remarkable. Now, remember, of course, that it's not fair to say it just about daratumumab. Remember, isatuximab is there as well. And so isatuximab looked at this as well. And what they did instead of dara, bortezomib, lenalidomide, or DVRD, they looked at carfilzomib, a second-generation version of bortezomib. They did ISA, carfilzomib, lendex, so ISA-KRD. As you can tell, we talk about a lot of acronyms. I sometimes wonder whether or not Dr. Sandu and I are speaking English to each other. But very similar results. And what they found is that the combination of the 4 drugs all up front is quite remarkable. And they're showing the very similar things too at 8 to 10 years of trending and what we expect to be the average remission after this quadruplet therapy up front. Now, the flip side of that and things that we talk to each other about is, well, if you give your all 4 drugs up front, and those are your 4 main classes of therapies, what do you do when they relapse? And that's where some of these new next generation therapies come into play. So, these two things are appearing to dovetail, different developments, but seem to be dovetailing at the same time. And so to kind of illustrate that long-term remission, this is actually the original phase 2, an earlier clinical trial. And this is called a Kaplan-Meier curve. In other words, this is actually following patients' outcomes over the course of time being on the bottom horizontal axis, the percentage of people that are still in remission, depending on what time you're looking at. And the basic idea is that you want to see the 2 curves separate. And so the top curve, the one in yellow here, is the quadruplet therapy. More of those patients then, with the staying higher, are in remission at each time point as you go farther out. And so as you can tell, this was published after about, I believe, an average of about 4 years of follow-up time. There are far more patients still in remission that got the quadruplet therapy compared to the traditional 3-drug therapy as we use right now. So interesting. So the question, though, that was in transplant-eligible patients. What about patients that are not transplant-eligible? As you just heard me say, that transplant-ineligible patients tend to do just as well. And so why is that the case? Well, to be honest, the quadruplet therapy actually works for them too. So this is a Cepheus trial. In fact, actually, some of our patients participating in this as well. We were, I want to say, the second highest recruiting center in the entire world on this clinical trial. And so this is transplant-ineligible patients that would get the quadruplet therapy for a predefined 8 cycles, not the entire time, and then reduced down to the triplet therapy of DRD afterwards compared to lenalidomide and dexamethasone. And so by doing quadruplet therapy and then going down to a triple therapy afterwards, this is looking like it's actually going to work really, really well. And so I've put some of the results here. This is actually going to be presented at the International Myeloma Society conference in about 2 weeks from now. And what they found is that the minimal residual disease, or MRD rate, in other words, the number of people that are staying super, super clean in their blood and their marrow, which usually translates into a long-term remission, much higher in the people that got the 4 drugs, 61% versus about 40%. And so you can imagine that means these guys are probably going to stay in remission for a lot longer as a result of that. So in the transplant ineligible population, that's going to change how we treat as well, where realistically, if we add the 4 drugs up front, that's going to hopefully predict for a much, much longer remission right off the hop. So, and it's actually trending to actually have an overall survival benefit. In other words, those patients seem to be looking like they may, in fact, actually live longer compared to the people that didn't get that combination up front. So daratumumab and isatuximab, we've been talking about these drugs now for over 10 years, and they are still continuing to change the way we treat myeloma patients. Adding them starting from the back of the line and then now obviously coming up to the very beginning of the line has made huge differences. Now, that's not always the case. I'll give the example of, for example, pomalidomide, a next generation lenalidomide equivalent. It clearly works in the heavily relapsed patient population, but unfortunately, as we moved it up into earlier lines, it tended to peter out in terms of its effect. That hasn't happened to daratumumab and isatuximab. Those drugs just continue to work really, really well and are very vital to what we use as therapies for myeloma patients. And the quadruplet therapy really doesn't matter if you're transplant eligible or transplant ineligible, it just bloody works. Yes. Yeah, so the quadruplet contains classes of therapies, a proteasome inhibitor like bortezomib, a immunomodulator such as lenalidomide, a 38 antibody of either daratumumab or isatuximab, and then the fourth one is dexamethasone or steroids. I tend to gloss over the fourth one is steroids because everybody loves steroids, right? So no problem. Any other questions before I flip into immunotherapy? And don't kill me if you're on dexamethasone on my way out, okay? All right, so moving on to immunotherapy. So the idea with immunotherapy is how do you get the immune system to re-engage? Now, one of the classic hallmarks, the original paper that talked about cancer therapy said that there were 10 specific hallmarks as to why a cancer develops. One of those specific ones is that the immune system unfortunately forgets to kill the cancer. In other words, that the cancer has either figured out a way to hide from the immune system or has found a way to shut it off. And really it depends on the cancer. For example, in melanoma, skin cancer, the cancer has developed a way to shut off the immune system. Not that it is avoiding it, it just turns it off. That's why the whole class of checkpoint inhibitors, things to take off the stop sign, really work in melanoma because basically it allows it to carry on. That same class of therapy hasn't really worked very well in either myeloma or in lymphoma because the problem is not so much that the immune system is being turned off, it's just that it can't actually properly recognize the cancer cell. Excuse me. And still thinks of it as a normal plasma cell, which obviously it is not. And so how do we get it to re-engage? So part of it, of course, as you heard from the discussion with daratumumab and isatuximab, is that you have to go after a specific target. You have to go after a barcode that is unique to the cancer cell. The ideal treatment is something that is very specific to the cancer cell and doesn't hit anything else, because that's how you avoid side effects. Now, there are multiple candidates that are potential for that of myeloma, so starting with all the different ones in box A, going to very specific ones in box B. And so in box B, the ones that are very unique to myeloma cells are illustrated there with BCMA, B cell maturation antigen, CD19, which actually shows up on B cells as well, and is the target of the CAR T cells right now in lymphoma. And of course, there's some very unique and funny ones. So this is where the students also go crazy, because what the heck does GPRC5D mean? And the short version there is G-coupled protein receptor 5D. So there won't be a quiz after, I promise. But obviously you can tell that we're starting to get into the weeds, and where the medical doctors are now having to learn a bit more about basic science and some of the immunology around it as well. So as you can imagine, with the CAR T cells doing gangbusters in lymphoma and leukemia, that led to a lot of development in the myeloma world as well. And so I showed this slide last year as well, that there are still 4 CAR T cell products that are out there. The 2 that are really kind of actually making any type of movement right now are the one on the far left, BB2121, which is essentially ide-cel, and then J&J 4528, otherwise known as cilta-cel. And now I'm going to talk about cilta-cel particularly here. I will talk about ide-cel, but cilta-cel is the one that we are more likely to be able to get in Canada as a standard of care in the near future. Now, to give an update as to when in the near future that would be, really difficult to say. As was mentioned to someone else, that the regulatory pathway is not easy. And to be honest, Janssen, who makes the CAR T cell, has not made it easy on the negotiators either, in the sense that the list price, and again, this is not trade secrets, this is a published knowledge, is around 700,000 a product. So it is a pretty penny to say the least. So why the enthusiasm? Well, this came from CARTITUDE-1. So CARTITUDE-1 was the original CAR T cell trial for cilta-cel. Sorry, I should backtrack. Cilta-cel actually started off as part of a Chinese company called Legend Biotech. Now, again, being Chinese, I feel like I could be racist to my own people. Whenever the Chinese publish data from China only, you have to take it with a grain of salt because they never tell you everything that they did. So is that real? So Janssen took the same thing. So they saw the original Legend Biotechnology data and said, you know what? I'm going to repeat that study because I'm not sure if I can believe this data. So that's where CARTITUDE-1 comes in. This is essentially a repeat of Legend's original clinical trial, where they essentially do what's called a phase 1 clinical trial, dose escalation, where they're trying to see how safe is a drug and does it actually work. And so they took a very heavily pretreated population. You may not be able to see this, but the patients that got onto CARTITUDE-1 were heavily treated. These guys had at least 5 prior lines of therapy, anywhere from a range of 2 all the way up to 9. So these guys have seen quite a few different recipes over the course of their lifetimes. Now, this is a patient population that realistically has not a lot of good therapies left, so you can imagine that traditionally we expect these people not to do well in a very short period of time. And again, Kaplan-Meier curve, so time is on the x-axis there, and what you're seeing is that these guys are actually living quite far out. In fact, actually seeing a bit of a plateau where essentially there are some long-term remission patients well past 2-3 years. The update of this study actually shows that the average remission is about 3 years with this CAR T cell in that heavily pretreated population, which is not seen, period. And so the reason why that I talk about cilta-cel more than ide-cel is because, sorry, I didn't put that slide in, is that ide-cel doesn't seem to get that same 3 years of remission. Ide-cel gets about 1 year, still great, but compared to 3 years, I think realistically, if you only had an option of one CAR T cell, cilta-cel in that specific population makes sense. Now, as we just talked about with daratumumab, isatuximab, the earlier you move up these therapies, the better they tend to work. Part of it is that the immune system is not quite as tired after all that chemotherapy. It also means that the patients are younger and healthier compared to where they will be in the future. And so that's part of the reason why that moving both of those CAR T cells up makes sense, and that ide-cel, in fact, may actually do really, really well in the upfront setting. So this is where this came about in terms of, well, if it works really well in that setting, what if we were to move it up? And so this is called CARTITUDE-4. I'm skipping over 2 and 3 just because they were kind of incremental improvements. They took patients that had relapsed after their first recipe of therapy up to their 4th recipe of therapy. In other words, these guys are much less treated. And what they found was actually compared to standard treatments, cilta-cel did a whole lot better. These guys are by far doing much, much better over time compared to those that got the standard chemotherapy regimens that would happen at the subsequent relapses. And so in fact, that's part of the reason why that we keep pushing to say, can we please get cilta-cel, because it clearly works. Now, as I mentioned, ide-cel does work as well. And in comparison to standard of care treatments, it does improve upon the standard treatment. So, if I had to get a CAR T cell right now and I only had ide-cel to use, I would still use it because obviously these patients are doing better compared to standard of care treatments, traditional chemotherapies. It's just that, in cross-trial comparison, which is technically not fair, cilta-cel seems to be doing a bit better. And so if money is a problem, which it always is, if I had to pick one or the other, cilta-cel is what I'm trending toward, and that's part of the reason why that, when we talk about funding and whatnot, if we're only going to get access to one CAR T cell, I'd rather be cilta-cel compared to ide-cel. But if everything were fair, like I said, if I had both CAR T cells in front of me and I was only allowed to use ide-cel, I'd still use it. Now, that's just going after one target. That's going after that BCMA. So remember that part B where there's one thing that sticks out BCMA. What if you target one of the other ones? So this is where that GPRC5D joke comes into play. In fact, actually, folks have developed CAR T cells going after this as well. And it does work really nicely. So this is a bit of a busy figure, but the short version is that these are patients that had relapsed after BCMA-directed therapies, things like CAR T cells and bispecifics, and they applied GPRC5D targeting CAR, and it still works. These patients were getting on average about a year to year and a half of remission time before then their myeloma subsequently relapsed, but it works really nicely. The only trouble is that this target is not as clean as BCMA. In other words, GPRC5D is found on other tissues, like the tongue and it causes problems with taste changes. And so some of my patients who are on a targeting therapy going after this target will tell you that their taste buds don't work quite right. So CAR T cells, increasing evidence, it's growing, it's moving up into the earlier lines of therapy. And while I didn't have a slide about it, we are about to launch something called CARTITUDE-6 here locally as well. So this is an international study with Janssen, where if it works in those relapse settings, what happens in the newly diagnosed patients? And so this is a study where patients are getting that quadruplet therapy, that DVRD upfront, and then they're getting randomized into stem cell transplant versus CAR T cells. So this is a flip of a coin. Now, I like the study because even if you're going in the standard treatment arm, you're getting access to that quadruplet therapy, which I just showed you works gangbusters compared to our standard triplet therapy. So for me, patients are getting win-win no matter what arm they get. Now, obviously, patients, I'm assuming, are wanting to get onto the CAR T-cell arm, but I'm telling patients right now that this is going to be beneficial no matter which way you cut it. Now, is CAR T cells going to be better than the stem cell transplant in this upfront setting? I don't know. As I mentioned, that DVRD, that quadruplet therapy, works so well that it's going to be hard to really improve upon that. Now, yes, there is room for improvement because as you saw, that curve no matter what still comes down over time, but we're going to have to wait a really long time. If patients are taking on average about 8 to 10 years to relapse after DVRD and transplant, gosh, if CAR T-cell is going to work better, that means these guys are going to have to get 12, 14, 15 years afterwards. That's a lofty goal. Now, if they hit it, fantastic, but at the same time, that we're going to have to wait a long time to know whether or not CAR T-cells has improved upon a stem cell transplant. Now, is this the nail in the coffin to transplant? Maybe. I think the reality, of course, is not one myeloma patient is going to be quite exactly the same as the next one. And so will I ever say we're never going to do transplant again? Well, of course not. I mean, there's going to be that unique scenario where the transplant makes sense for that person. But CAR T cells is really, really making a huge wave, as you can see. Now, that leads into bispecific antibodies or bispecific T-cell engagers. Now, I used to call these BiTEs. Unfortunately, there was a bit of a lawsuit where the original guys that developed the name BiTE, Amgen, said that's our trademark. So from here on, we're going to call these bispecific antibodies. I kind of miss calling them BiTEs. They're way easier to say. The basic idea in the technology is that rather than having to engineer a T cell, rather than having to manipulate a patient's T cell, can we just add a drug that wakes those T cells back up? And the answer to that is yes, you can. And so this is along the lines of daratumumab and isatuximab, but rather than hoping that you're going to get the T cells to go in on this, you're particularly targeting T cells now as well. So one part of the Y goes after the cancer cell. The other part of the Y of the antibody then drags the T cells to the site and tells them to turn on. So rather than having to manipulate a T cell, it's actually just telling the T cells, come with me and go kill the cancer. Now, obviously, without engineering the T cell to do so, there is still a bit of a gap where realistically you're still hoping those T cells are functional before you put them, when you put the drug in. But the large majority of the time, this type of therapy does work as well. And I'm going to show you in a second. There are a lot of bispecifics now out there in development. The two that I've highlighted here that are going to make it to standard of care usage in the next year or two are elranatamab and teclistamab. We'll call it Elra and Tec from here, just so that way I can not get my tongue twisted. But Elra and Tec are studies that are two drugs that we had in clinical trial quite a bit. In fact, actually, bit buried in the middle of this one, right there at the bottom line there. But we participated on the very first trial with Magnetism-1, and as well as teclistamab, though in this one, unfortunately, we didn't get in early enough to really put too many patients, but Dr. Nizar Baylis is in this paper as well, one of our colleagues from Calgary. So we're fortunately getting availability and access to some of these earlier treatments in order to give them a go. Part of course, is some of our expertise in immunotherapy, but part of it too is our willingness to give it a shot. So thank you to all of our participants who are willing to take a shot on some of these immunotherapy studies. Now, you're not going to be really able to see this. I put that there so that way then you can, if you want, you can go back and refer to it. The short version is that it doesn't seem to matter which bispecific antibody you get, they both really, really work. And now they do have slight differences in terms of timing, how often you have to get them. They're all intravenous still at this point. Though to be fair, we have then since adopted the subcutaneous formulations on all these studies, but the first version on the study was intravenous, now subcutaneous for everybody. But how long they work for, what types of side effects they cause are pretty much the same. To be honest, I see them as being quite interchangeable. So compared to ide-cel and Cellular, well, there's a clear difference. It doesn't seem to matter whether you get Elra or Tec in this case. They both work really, really well. Now, the side effects of bispecifics, very similar to CAR T cells. In other words, that the stimulation of the T cell happens even if you just use a drug. So where you think where CAR T cells, if they're much more severe, should end up with more severe side effects, that's probably the case overall. But no matter what, bispecific patients can still definitely run into that overstimulation of their immune system, which then can lead to some really weird brain side effects, which are fortunately temporary. At least that's what I tell patients, but kidding. Now, some of the practicalities, of course, the benefits of it is the bispecific is an off-the-shelf therapy. For a CAR T cell, for a standard of care CAR T cell, you have to take the T cells out. It requires a central line, so a lot more poking, requires a time on a machine. The cells have to go shipped to the manufacturing center and then come back, which takes on average 3 to 6 weeks. Whereas bispecific antibody is a drug. I could pull it off the shelf and give it right away if it was a standard of care therapy. So you're talking about hours versus weeks. Now, obviously, the problem there is that the bispecific antibody as a drug is a continuous therapy. Once we start it, we don't stop it, it just carries on. Whereas a CAR T cell is a one-time therapy and then you get a break for a really long time. As mentioned with cilta-cel, if you get a 3-year average remission time, you get one treatment, you're done with therapy for 3 years. As many of you will say, what? I'm on continuous therapy. That doesn't seem very fair. I agree, it's kind of strange. A very weird thing for us in the myeloma world to be thinking about too, which is a 3-year long break from therapy. Now, the other part of the thing is that some of the long-term complications with the infectious complications are both the same. CAR T cells and bispecifics, because of how tiring it is to the immune system, patients will still have to get a lot of adjunct therapy to try to improve their immune system. So things like intravenous immunoglobulin, where we basically supplement the antibodies in the body. Now, there are other ones. So just like there are other CAR T cells, there are other bispecific antibodies, telcutamab, or TAC, as I call it, for GPRC5D, and then cevostamab targeting FcRH5. So telcutamab is actually a bispecific we've studied in the clinic here in Edmonton as well. And in fact, actually, the one that I'm showing here is something that is not yet presented. So again, you take it, put it under your hat for about another 2 weeks before it becomes public knowledge. And the reason we have access to this is because we participated on the study. I think that we were the 2nd or 3rd highest accruing center in the entire world as well. So again, thank you to all the patients for that. This combination of 2 different bispecifics, the idea again, just like it is with the quadruplet therapy, if you put more than one of these things together, does it work? And to be fair, when we started the study, that wasn't a foregone conclusion. We were quite worried in the very beginning that we're just going to really tire out the immune system and then everything was going to shut off and not work. But that's actually not the case. Going after 2 different targets with a bispecific antibody really, really works. So a bit of a busy slide. The short version there is that the large majority of these patients respond to this therapy, and those responses are really, really deep. In other words, the targeting 2 different targets with a bispecific antibody really gets deep into the patient and helps to get rid of those things, including patients that have what's called EMD, or extramedullary disease. Some myeloma patients will develop lumps and bumps, whereas we think of it more as a blood cancer. Some of them actually will develop little tumors, things in the skin as well as muscles. And this treatment works in that population as well. And that's not traditionally the case, where a lot of the traditional chemotherapies we use for myeloma doesn't seem to work in this patient population, but this combination does. So again, a busy Kaplan-Meier curve. Just look at the very top one there, where the patients that are on the actual proper dose are getting nice durable remissions. About 70% of patients are still in remission at 18 months. And this is, again, studied in a patient population that had seen quite a few other therapies. It was a requirement of 3 prior lines of therapy. So not quite as heavily pretreated as the CAR T cell trial that I showed you, but still a very heavily relapsed population overall, with an average of 3, anywhere up to 7 is what the patient population has looked like. And these guys are getting durable remission. As you see that hit a plateau, where against those guys are in remission at 18 months are still staying in remission. As some of you will know, and those that have participated, we have some of these guys that are 3-4 years out that look remarkably well, and that we have no idea when to stop. The other nice thing about this treatment that we've found, and that doesn't show up in this abstract, is that you can take ridiculously long breaks on this therapy. So for example, if someone is doing well, they're in remission, we've actually taken breaks of between 6 and 9 months for some patients, not seen a relapse. We start them back on therapy more so just because it's weird, and we get a little bit concerned about not starting another line of therapy. But like, well, is there something going on in the background? Who knows? So then you just want to start it up again so you don't miss the opportunity to continue on the treatment. At the same time, some of these guys are doing remarkably well. So again, this is the new age of therapies, where the combinations of these immunotherapies are starting to come out now on top of just the one drugs that we've been using traditionally for the last few years. Again, in the slide that I showed last year as well, and just a brief reminder that some of these therapies are things that we are going to combine or do sequentially. So in other words, can you do a CAR T cell and then a bispecific, 2 different immunotherapies doing somewhat similar things? The answer to that is yes, but it does depend on the order. Doing a bispecific before a CAR T cell actually doesn't do very well. In other words, remember that you're taking the T cells out of a patient. So if you give an immune therapy, tire out the T cells, and then you try to turn them into CAR T cells, well, they don't work as well as compared to the other way around. If you made a CAR T cell first and then gave them a drug to stimulate those T cells, that works better than the other way around, and that theoretically makes sense. Where this is going to get complicated is, as I just mentioned, and again, unfortunately, we have to talk about money in this situation. I don't know if we're going to be able to get access to all of those therapies for an individual patient. In other words, if a CAR T cell costs $700,000, are we going to be able to provide a bispecific antibody that continues therapy at somewhere between $10,000 and $20,000 a month continuously after that? I don't know. I think that from the bean counters are going to say, wow, that's a lot of money, and it kind of is. So this is where some of the other areas of focus that we are trying to do are, how do we make this cheaper and how do we make this in homegrown? Something that I haven't shown here, but we're about to publish as well, is that our own CAR T cell program in lymphoma saves an average of about $430,000 per patient. So I joked with the government times that we've done 30 patients on trial. That means I've saved the government about $13 to $14 million. Where's my money? But unfortunately, no. But the conference actually is going to be in Honolulu. So I suggest, well, instead of that, you can buy me a first-class ticket to Honolulu to present the data. Crickets, unfortunately. But having said that, I mean, this is where the idea comes from. Well, if you develop a program that essentially makes your own cell therapies, then are you as reliant on these ones? Well, yes and no. I mean, remember that there are nuances to the technology, and it wasn't part of this discussion, but one of the reasons why we think cilta-cel works a little bit better than ide-cel is that the technology behind cilta-cel is a little bit better, where there's a bit better of a binding onto the target. So even though we're developing our own, will it be better than the standard of care? We don't know that. That's the whole point of the clinical trial in this study. But where we're going for right now with us internally here is CAR NK cells. Now, NK cells are another part of the immune system, unlike T cells that are called natural killer cells. So you imagine these guys should be really good at killing cancer, and they are. And so can we modify them and turn them into supernatural killer cells? The answer is yes, you can, but the difficulty is that they don't tend to behave the same way that T cells do. T cells you can manipulate, you can make them grow, they basically do whatever you want them to do. You try to do the NK cells and they kind of give you the middle finger, unfortunately. So I can tell you now that one person's NK cells do not behave the same as the next person's NK cells. And so that's part of the reason why that we've gone to the tact of either using healthy donor or cord blood NK cells from newborns. And they don't multiply as nicely as I want them to. So T cells will multiply every 2 days when you're growing them in the lab for CAR T cells. NK cells have been taking weeks in order to do the same thing. Having said that, over the past year, we've been pushing them and kind of tinkering along the way. I think that we've gotten to the point where, number one, we've identified the right NK cells. Number two, we can make them grow quite nicely now. And number three, we found a way to actually really get the CAR gene into them. So we definitely had some significant advancements over this past year that are going to hopefully lead to a translatable CAR NK cell clinical trial in the next year. But finally making some headway. As you can tell, it's been a frustrating ride, to say the least. But the one benefit to using CAR NK cells compared to CAR T cells is that if we can actually hit it, the projection is that each cost of treatment is a few $100s, not hundreds of thousands of dollars. So that, I think, to me, makes a huge amount of sense if we can stick the landing there. But that's what we're trending toward. More along the traditional routes, so a couple of my colleagues in Calgary, Kevin Hay, is working on what's called a nanobody BCMA CAR T cell. In other words, changing the targeting method of the CAR T cell. And Dr. Bayless is working on an armored CAR T cell. In other words, a way to try to keep it alive for longer and a little bit more trigger happy, if you will. Both of those are interesting and are likely to come into clinical trial in the next year or so. Dr. Bayless is probably the closest, and something that will hopefully get into clinical trial sometime in 2025. So definitely some movement here in Alberta in your own backyard, and things that are trying to be developed. And so a couple of very brief notes on some of the other therapies. I've covered quite a bit already. One that I want to bring up is belantamab mafodotin, or belamaf for short. Belamaf is a very interesting therapy. It's much more like a traditional chemotherapy in the sense that it's an antibody tagged onto a very heavy-duty chemotherapy. Think of it as like a heat-seeking missile. Works really well. The weird thing is that it causes a bit of a weird corneal effect. In other words, it causes a bit of a thickening to the eye, to the part of the eye. Now, from a patient perspective, you don't feel it. It doesn't cause any pain, doesn't cause any eyesight problems, but if you leave it long enough, it actually will eventually cause eyesight damage. But the nice thing is, kind of like the other therapy I mentioned, you can actually take 12 weeks off this therapy as long as you're in remission, And it doesn't matter, it stays under control. It allows the eye issues to go away and you can restart the therapy again. So belamaf has actually been a very unique therapy and something that should get approved eventually. Now, unfortunately, it doesn't quite work in as great a proportion as people. As you just saw some of those other CAR T cells and bispecifics, 70–80% of people are responding. A little bit less so with belamaf, but at the same time, a very effective therapy, including people that have been treated with CAR T cells. So I do expect that to eventually become a standard of care therapy. In fact, we participated in a belamaf trial in the very upfront setting, newly diagnosed patients with combination. Works really well. Probably one of the other, I call it a quadruplet light therapy. Selinexor, as some of you may or may not have been exposed to, is a drug that's been around for a while now. Much more like traditional chemotherapy. Not my favorite drug to use because unfortunately it does cause quite a few nausea-related side effects, but still an effective therapy in about a third of patients. And then the next generation of lenalidomide, things like iberdomide or mezigdomide or CELMoDs, have worked. It's just that they're trying to stick the landing. They work better together with other therapies. Where I see the next combination therapies are adding these next generation immunomodulators, the next generation lenalidomides with CAR T cells as well as bispecifics. So while I haven't talked about much, those guys are going to be the next generation of combination therapies that are going to be coming out in the next 3 to 5 years. So an explosion of therapies, which is good, obviously. Now, the problem, of course, is that we're still not getting away from the main treatments of the quadruplet therapy, as I mentioned. These bispecific antibodies and CAR T cell therapies are very interesting and have continued to work as they've moved up the line. Will it be better than transplant? Who knows? What about in the transplant eligible population? We're actually looking at with an ida-cell trial, so the transplant eligible population, we're going to try to give CAR T cells to as well, just because it is a little bit lighter compared to heavy-duty chemotherapy. But again, a huge explosion of therapies in the last 5 to 10 years in particular. And with that, I'll stop there. Questions?
Okay, so please remember, don't ask your question until you get the mic so our online folks can hear.
Thank you, Dr. Chu. I have a question for you. So if you are on one of these wonderful new therapies and you need to have IVIG, is that permanent or is it just until things resolve?
Yeah, it's a great question. The answer to that is I don't know yet. It's looking like more and more that it is permanent while you're on the therapy. Now, where I'm hedging on this is that that's different between bispecifics and CAR T cells. CAR T cells, it seems like it's temporary because what we know in CAR T cells is that usually the antibodies and the immune system tend to restart themselves after about a year after CAR T cells. And so that probably means that the IVIG is time limited for about a year and then your own body carries on. Bispecifics, not so much. That seems to be more of a permanent thing while you're on the bispecific because no matter what, we keep tiring out the immune system with that continuous therapy.
Thank you.
Hopefully subcutaneous IG will come out and that way we can actually avoid having to do the intravenous all the time. The difficulty with subcutaneous is that the IVIG is monthly, the subcutaneous is weekly, but there's a self-home administration program that's hopefully going to come with that. So that way you don't have to always travel into the cancer center to get that shot.
Hi, Dr. Chu. You didn't talk about stem cell and cost, but I was kind of curious, what does it cost for a stem cell transplant versus a CAR T when and I don't even know, are you doing it in person or how are you doing the stem cell now? Just the difference.
Great question. So stem cell transplant is roughly about $100,000 to $150,000 per patient. That's including all the care costs. When I mentioned about $700,000 for the cilta-cel, that's just the product cost. It doesn't actually consider the clinical care cost yet. So as you can imagine, that's quite expensive when you add that on top of another $100,000 to $150,000.
Hi, I'm just wondering, is there any research that's underway regarding the applicability of, let's say, CRISPR technology in the treatment of multiple myeloma?
Yeah, great question. So CRISPR technology, for those that don't know, is a way of gene editing that's a little bit different from how we make CAR T cells right now. So I use CAR T cells as an example. CRISPR technology can be applied along a lot of different routes. So right now, to make CAR T cells, we actually have to introduce a virus that basically injects the gene that we want, but it does it randomly. CRISPR is a way to actually do this a lot more targeted and a lot more finessed. Rather than randomly hoping that the virus works and it inserts where we want it to go, CRISPR allows us to not only target the specific cell, but the specific part of their gene that we either want to cut out or put in. So to answer your question, yes. I think that where CRISPR is being used the most right now is a modification and update to CAR T cells to make them better and easier to make as opposed to viral insertion. People are using CRISPR for a variety of different processes as well, some of which is actually manipulation of the immune system to actually, as opposed to making CAR T cells, can we wake up the immune system by adding a CRISPR bit of editing to their immune system to then hopefully wake up internally without actually having to make a CAR T cell to begin with. Apart from that, those are the two main areas where CRISPR is being applied at this point in time. But as you can imagine, CRISPR technology has a lot of applicability along the way. I think the difficulty is CRISPR is not as specific or as effective as I think that we wanted it to be in the lab translate over to humans. So, you know, when we talk about CRISPR, we're hoping that it be 100% specific. It seems to be close to be about 70 to 80% when it applies to human clinical trials at this point in time. So something that unfortunately still needs a bit more finessing before it sees the light of day.
Dr. Chu, what is happening when you have a patient with 4 drugs? The 4 drugs have been very highly effective. And then they are taken off, some of them. Is that the immunotherapy? Is the body taking over? And is there hope for that in the future?
Yeah, so that is the hope, to be honest. And so I didn't get into the details, but in fact, actually, the quadruplet therapy that were being applied to the transplant-eligible population, they actually stopped therapy. So after their transplant, they go on for 2 years of daratumumab and lenalidomide as a maintenance, and then they stop, provided they're in a complete remission. So if on the blood testing, the bone marrow, there's nothing to be found, they stop those patients. And then they wait and see. As soon as their numbers start to climb again, that's actually when they reintroduce the exact same drugs, thinking it as a treatment holiday, and seeing whether or not that allows them to essentially stay on the same therapy, but for longer. And so in fact, yes, the thinking is that the immune system resets and is actually able to go after the myeloma cell now that it's been woken back up through stem cell transplant as well as the quadruplet therapy. And that's what we think is actually what's driving that really long-term remission afterwards.
And have you noticed relapse in those long-term patients, or?
I mean, these guys are going a long time, to be fair. I think 2 patients, so it's not a really big sample size locally, that have actually been able that have relapsed after the quadruplet therapy. But both of those patients were around the 8 to 10 year mark before that happened. So quite remarkable. So quite frankly, both of them were restarted on the DRD. So the original therapy, basically without the bortezomib. So instead of quadruplet, they were put on a triplet, and they both responded again. So
Amazing.
right?
That's amazing.
We were quite impressed by that as well.
Yeah.
So.
Amazing. Thank you.
Anybody else? Sophia, how's online looking? Oh, there's one. Okay.
So if I read this right, how does valacyclovir relate to?
Thank gosh, Dr. Chu, because I didn't know how I was going to read
Problem. Yeah, no problem. How does valacyclovir relate to help or augment a Dara-Dex-Rev combination? So part of the problem is the immune system takes a hit from the therapy, the daratumumab in particular. Daratumumab, and to be honest, almost all of our chemotherapies that we use for myeloma, unfortunately really weaken the immune system for some of these long-term or chronic illnesses, like I mentioned with CMV. In this case, we're talking about herpes simplex virus 1, the virus that causes cold sores. If you were to develop cold sores and 90% of the population has been exposed to this virus, it stays dormant. It never really goes away. It's just that when you have a normal immune system, it just keeps it in check. But anything that allows weakens your immune system will allow it to come out, in this case, chemotherapy. And that's the reason why valacyclovir is there, is to prevent that from happening, just more so because once you develop cold sores, it allows for bacteria then to get in. Bacteria then cause more serious infections. We just don't need any of that if we can help it. Valacyclovir, really cheap old drug that really we've studied quite extensively over millions of people, extremely safe. And that's part of the reason why we feel very comfortable leaving people on it long term. I realize it's another pill that you have to take long term, but it's better than the alternative in my mind. Any other questions?
Come on, guys, we've got them here.
My kids are swimming right now, so I've got time. Yes. No problem, Brian.
Nothing more? All right, we're going to say join us for lunch if you have time while you wait for your kids to finish swimming. But yeah, no.
Thank you.
Thank you.
Errands to run, so I won't be able to. But if you had a question that you didn't want to bring up publicly, by all means, bombard me as I'm walking out. I don't mind at all.
Uh-oh.
Maybe don't tackle me. That's all. But
You realize this is all being recorded.
yeah, that's okay too. I'm hoping my slides will be able to, like I said, some of those tables comparing ELRA and TEC are really hard to read, but that's the reason I put it there, is so that you can review it later on at your own leisure and your own pace. But truly, I mean, again, thank you, just because obviously research is hard, and as we learned from the CAR NK cells, not a straight line. We thought that having understood CAR T cells quite a bit, we'd be able to apply that to CAR NK cells. And gosh, I mean, this is where the body and biology and nature just humble you, realizing that you don't know what you don't know. And having said that, I mean, obviously making headway and looking towards something that looks quite promising in the near future. It is a growing field. We are working on a national level now with respect to some of the other colleagues. There's a group out of Ottawa that's been looking at CAR NK cells. The hope is that actually we may have a candidate CAR NK cell to bring into trial in the next year, just to see how it goes. I think that our own, again, this might be my own bias, but I think my own internal CAR NK cell works better than the Ottawa guys. But having said that, that's partially because we knew where the field was and we knew what to improve upon. And that's part of the reason why we've taken our time trying to get it done right, as opposed to just coming out with one. Not to say that it won't work, it's just that we have a reason to believe that ours may work better and for longer. So. Awesome.
Yay.
Thanks, Lauren. Great. Awesome. Thank you, everybody.
Thank you, thank you, thank you.
Thank you.